drugs, especially since we already brought it up, this is obviously just saying, you know, Schedule 1, it's what they would say is least amount of benefits, most amount of risk. It's fascinating to me as a person that's not a huge supporter of marijuana. It is lunacy that it's up there with heroin. Like, whatever, dude. Like, oh, the risk factor is, I really don't think that's true, but whatever. Certainly, political agendas are in no way affecting this. Anyways, so what this looks like is as we go farther up, so closer to 1, we're saying way more risks with little proof of benefit. And on the other end, we're saying lots of proof of benefit with next to no risks. Incidentally, I've not met a bunch of people with weed issues, and I've had a whole bunch of patients OD on Robitussin, but what do I know? Okay. I don't want to talk about the drug administrations. We don't use these classifications currently. It's more of a narrative structure, meaning instead of a drug used to say this is a class A, this is a class C, they found that that just really wasn't communicating the idea. So now on something like Zofran or Ketorolac, you'll see a little paragraph officially about what they found and what they haven't, which is good because it's good detail, but it doesn't really roll off the tongue anymore. It's just saying, hey, it's a class D, hey, it's a class B. So I won't require you to know these pregnancy classes. I will say that I would not quite eliminate it from your brain. You should know that X is bad and A is acceptable, because even if you don't get asked these letters on registry, conceptually it's still important to know that there is stuff that we have tested on humans and are A-okay. We've tested it on humans and we're fine with it, even if we don't call it A anymore. Then there's stuff down here where we've tested it on animals and noticed no issue. Not really sure about the people, so we just keep using it until we can test it or prove it. Then we've tested it on animals and we see some problems here, but again, we haven't tested it on people. We're not really sure, but we are seeing problems with animals. D is we tested it on humans and showed increased risk. We are consistently finding problems with fetal development and use of this medication, which is where Ketorolac used to fall. Okay? Or X, we have tested it, and 100% of the time, or a major amount of the time, we're seeing fetal development issues. You should in no way give this, right? Again, they're not charted this way anymore. They come with little narrative paragraphs, but I still think conceptually it's good thought processing. Oral glucose, I want to spend 0 time on, or asthma for that matter. We'll get more into this in respiratory. The biggest thing that I want to see changes here, and I haven't added it to this slide, does anybody see in my notes our changes to both albuterol and Atrovent? It's might be a little harder to pick out, but I did list it in the notes.
ETCO2.
ETCO2. ETCO2 is basically here's what's going to happen. You know how like I teach you to check temperature every single time, and then you get laughed at in the field when they're like, temperature again? Yeah, I'm like, okay, they're dumb, we're not, ignore them, right? And the same thing is true here in end-tidal, where you're gonna go out in the world and you're gonna be like, dude, like, no one does end-tidal. And I'm like, I know. And you're like, it is so valuable. I'm like, I know. I don't know why. So at this point, if you're think that a person has an airway concern or will develop an airway concern end-tidal.
Is that what you said as a shark fin?
That's correct.
Yeah,
That's correct. If you put every patient you ever meet on end-tidal, you will never be wrong. It might be wasteful and unnecessary, but no one's getting marked down for that. And I would just as soon as see 80% of your patients on end-tidal. Just know that that is not the culture out there. And it's largely because people don't understand the end-tidal and what it offers us. Suffice it in the simplest message to say, hey, I think you're having a breathing problem. Then that should mean lung sounds, oxygenation possibly, maybe ventilation, and now end-tidal. If you're giving albuterol and Atrovent, you should be like, oops, I completely forgot about end-tidal. I'm not saying that you should do it beforehand or anything, but if you're affecting their airway and don't have end-tidal on, you've missed a step. You should have stayed EMT. If you don't do end-tidal. You don't want to do end-tidal? We got a job for you. This is now end-tidal world. You know what I mean? It is arguably the most important skill that you will take from this class, end-tidal. What is it? Okay. And we talk about epi. We now don't just say epi. Before, as EMTs, we would say, let's give them some epi. We now call it by its true name, not its slave name. In this case, we were specifically talking about the whole time about epinephrine 1 to 1,000. That's what we have learned. So the epi you know is 1 to 1,000, mostly. What are we giving this for?
Anaphylaxis.
Anaphylaxis. How do you know when anaphylaxis has occurred?
Oh no.
Yeah, sure. Yeah, breathing issues. I am taking closer and closer to just from the gate saying, you got something other than hives? Blast it. Epi. Right? Because what happens if I say 2 or more body systems and I show up and a guy's like, man, I ate a new food, I tried a new detergent, I used my wife's soap for the first time, I got bit by a snake, stung by a bee, all I have is swollen lips. And the EMT says, well, it's not anaphylaxis, it's just one system. Pass. Epi.
I don't trust that.
If it's swollen in the mouth, it might be swollen on the inside, right? I don't mess with that stuff. So 2 or more systems, or hypotension, or respiratory concerns, or angioedema, or, you see what I'm saying? I'm like, there are rare few cases where if you suspect an allergic reaction, you shouldn't be giving epi 1 to 1.
Is Benadryl an antibiotic?
It is.
Is it like complicated? Why is
No,
it not
I don't
used?
know. I don't know. I hate it. Especially since I gave probably more Benadryl than I ever gave epi because Benadryl was fantastically successful. Yeah, I do not know. We will have a longer discussion later. We used to just say that it causes, I don't know what we said, that its action was like sympathomimetic or something. I don't know what we said. But now we're of the mindset where we're like, no, it's not just epi, it's an alpha 1, beta 1, beta 2 adrenergic. And we'll learn those terms more in depth later. But for now, if I ask you, hey, what is the action of epi? I want you to say that it's alpha beta adrenergic or agonist or sympathomimetic affecting these receptors. That's where, in short, memorize this. Alpha 1, beta 1, 1 heart, beta 2, 2 lungs, boom. But no one is really surprised by this, right? I jump, big bear jumps out, epi floods your system, heart rate goes up, blood pressure goes up because of vasoconstriction, respiratory rate goes up, pupils dilate, right? If I shoot you with bear in the woods, right, then essentially it causes all those things. So again, our indication here is anaphylaxis. We know this as suspicion of allergies with basically any signs that isn't just urticaria, wheals, or rash. Our dose now becomes weight-based for pediatric. It's no longer 0.15, it's 0.01 milligrams per kilogram.
That's what it was. This is what it was.
Right? Will you be safe giving 0.15 milligrams 1 to 1,000 for the rest of your career? Yes, you will. No doctor in the world will care. If you're like, I didn't run the math on a doc, I gave 0.15. You probably won't care if you gave 0.3, to be honest. But you should know that 0.01 is now our dose. And so if you get a test question that says you have a 2-year-old, what is your dose? The answer will not be 1.5, right? Or, sorry, 0.15. That will not be the answer. I'll want an exact dose because now we're in a world where we need to know exactly what it is. And this is in large part because it is the same dose for 1 to 10,000 epi. And so I want you to know that. We'll get into that in just a second. What I want you to view is that 1 to 10,000 is strong. It's a high concentration. 1 milligram and 1,000, that's bad for veins. You better put it in the muscle. Okay? What that means is that our 1 to 10,000 dose is for veins. We've diluted it 10 times more. Instead of, I need some hands. Any give me hands? 10? Okay. I guess I should say like this. 1 finger, right? So this is my anaphylactic dose, 1 to 1, right? I basically, half of it is epi, let's just say. If it's 10, so now I'm like this, it's now 1 to 10 ratio. It's way less concentrated, and therefore easier and more, less likely to cause problems in the veins. So 1 to 10,000 epi is IV epi. 1 to 1,000 epi is not IV epi. And your adjuncts should be asking you to say, I'm gonna go ahead and pull up 0.1 or whatever, 1 milligram of epi, go ahead and administer that. They should say, what concentration are you using? And you should be able to answer, well, if it's IV, it's 1 to 10,000. Okay. Now, when you ask yourself the question of what does that mean, 1 to 1,000, 1 to 10,000, the answer is, I have no idea. My guess is that's just how math works. That we're talking about molecules or milliliters on a long enough time frame. Like, I don't have 10,000 milliliters, but that's how diluted it is. That for 1 milligram, it's 10,000 milliliters. I actually don't know. I'm not sure. In fact, I don't think that's the case, because if you look at your epi, I think it's molecules, not milliliters. This is 1 milligram in 10 milliliters. That's not 10, I mean, it is 10 times. I don't know why. I don't know what the ratio is the point. But this is 1 to 10,000. And this one here, you're called adrenaline, is 1 to 1,000. Do you note, look at your, it might be purple in most cases, where it says adrenaline, 1 milligram per milliliter. You'll note that nowhere on there does it say 1 to 1,000. You have to know that 1 milligram and 1 milliliter is the 1 to 1,000 concentration. So 1 to 10,000, it's IV administration, right? When are we using it? Not in anaphylaxis anymore.
Cardiac.
It's a sympathomimetic, it's alpha 1 beta 1 beta 2. It's used in cardiac arrest or neonates with heart rates less than 60. Because we treat that like cardiac arrest. What?
So it's because it's 1 gram and 1,000 milliliters.
Okay.
You can only measure in milligrams.
Yep.
So still, like, why would you do that for?
I don't know.
So there's 1 gram and 10,000 milliliters would be the ratio. They just typically say milligrams and milliliters.
Cool. Yeah, I had a student ask me that before I was teaching, like they're in my truck. They're like, what does that mean? I'm like, in 12 years, I have never asked myself what that is referencing. I don't know.
If you wanted to get a whole gram instead of milligrams, that would be the concentration.
Which you never will.
Yeah.
I don't know why. Now, our adult dose is 1 milligram. So, if you're in cardiac arrest and it's time to give epi, how much of your 1 to 10,000 syringe are you giving?
10 milliliters.
10 milliliters, right? Because the concentration is 1 milligram in 10 milliliters. Let's pull that out of the box and take a look at that. Right, now this is, I'm over here doing CPR. I'm like, hey, we're going to get rolling on some epi. Why don't you go ahead and get it ready for me? Now, there is a needle in this thing. Be somewhat careful. This is maybe the sexiest thing you'll do in an ambulance. Like, epi, got it. You know. Now, I don't ever do that. I do it over the garbage. My partner's not my mother. They don't need to be cleaning up after me, but it is fun. Anyway. So what we'll want to do is we'll want to peel off both of these things and attach the blue to this area, like an arrow pointing forward, and we'll just gently thread it together. Now there is a needle in here that you really have to try to get to, but it's in there, so be somewhat cautious. I have to fill out paperwork. Please, 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 don't poke yourself. I'll make you fill it out yourself and then I'll sign it. It
Don't
sucks.
worry, I won't. That's why I'm using my hands.
Now you gotta do the thumbs, dude. Yippee-ki-yay, yippee, boom.
It's like Narcan.
Yeah, very good.
Pretty much. It's like a bigger Narcan.
You just thread it until it's snug. It's snug, dog.
Which side? Because he popped them
We
off.
weren't using it. I didn't expect you to go.
Do we just want to go so easy? Is that all you wanted us to do?
Oh man, you want to snug it?
Did that bad boy? Just
No, I got epic.
crep it?
Okay, so now we've got this, right? This, does this one do it? So this one only has one option, which is needleless administration. Some of these will have adapters where like you can pull this one off and there'll be a needle, or sorry, it'll be needleless, and then you can pull the next one off and it'll reveal the needle, so you can put it in a port like that. You just kind of have to know what you're doing, what the product is. Now, admittedly, some of you may have epi on your fingers, essentially because as you tightened it, it kind of came out. There's nothing wrong with just withdrawing it a little bit there. It's not that big of a deal. In fact, as we start to approach these medications, even flushes in general, there's always like this big like, oh, let me tap this and let me get it all and da-da-da-da-da. Like, we're talking about minuscule amounts of air. The likelihood that it causes an embolism is like non-existent. Now, I can't stop myself from the habit, which means I'm always tapping, and then kind of getting that air out. But we're just looking to give the medication the air is of far less concern. So what I want to do, what do I want to do? We've got that attached, so I don't think it's an issue. So let's just replace it essentially. Now we want to unthread it for now, and just put it back together, being careful about that needle on the one side, right? Now, when this gets used up, presumably this is real epi because we just open the boxes, but this will be one of those situations where I'm like, well, we don't have to throw away the syringe, we can just fill it back up with water. So I would say, go ahead and just like use it when we need to, when you have live IV stuff or whatever. You can leave it for now because we might go through some dosing issues. Now, so I just mostly wanted you to see that like when we're using this for an adult, we're gonna give the entire thing, right? We're gonna push it into their corpse and just let it ride, right? Now, and we'll talk about it more in depth later, but we would often say this, we would say medicate, circulate, defibrillate. The idea is that we're gonna give that medication and then I have to push it around your body through CPR, right? Your heart's not working, we're gonna have to move it for you, right? Now we're giving this every 3 to 5 minutes. Did I put on your card 4? This is 3 to 5. I'm gonna tell you, 3 to 5 is the standard answer, but I do it every 4 minutes. Why do I pick that? Sure. When are we doing this, using this medication? Sets of CPR. I start a timer, I'm taking notes, 2-minute cycle is over, a guy says 30, okay, 30, I'm like boom, set of CPR, that's 1 minute, that's 2 minutes. He does go through the second set, boom, that's 4 minutes, epi. So I do it every 4 to keep track of 2 set cycles of CPR. You know? All right, does anybody remember what my pediatric dose is? Mm-hmm. It's the same dose as the anaphylaxis IM injection, which is 0.01 milligrams per kilogram every 3 minutes. So you have a 1-year-old in cardiac arrest. How much epi do I want to give? Now, there's certain math that we can talk about. If you're not at this place currently, the 10s are easy, right? I have 0.01 milligrams per kilogram. I have 10.0 kilograms. If I multiply these, all I'm doing is moving the decimal 1 spot, right? So this patient needs 0.1 milligrams per kilogram, a 1-year-old, right? How much of that syringe are you pushing?
Just 1 milliliter.
Not all of it anymore, right?
1 milliliter.
1 milliliter.
It's a 1 milliliter.
Now you can get there with math, desired over have. You can how much epi is in there, right? And this is how this would look. Is we'd say, okay, what is my desired over my have times my quantity? Well, my desired dose is what? Is it 0.1?
Yeah.
0.1 milligrams. How much do I have? I have 1 milligram in how many milliliters?
10 milliliters.
10 milliliters. So 0.1 divided by 1 is? Actually, super don't know. I know it's the simplest thing in the world. I know how to multiply it by 1. Is it just reversing it to 0.01 itself? Either put it in your calculator or be more assured of yourself.
0.1. It's 0.1.
It's 0.1. Okay, so I have 0.1 now times 10, which moves the decimal, so I need 1 milliliter. So again, you can either just kind of be like, well, if it's 10 kilograms, I just move the decimal. Or on Tuesday, I'll mail home this formula. I just mean to say is that, see what I'm saying? This formula is used over and over and over and over. And if you get lost in the woods, sit down with a piece of paper and do just that, right? Or have an app on your phone that'll do it for you, whatever the case. Okay, let's say you show up. We have a 6-year-old not breathing, cardiac arrest. How many milliliters are you giving? Talk to each other, nerds. Huh? Yeah, well, that's why I put you together,
I
because
feel like I
you're
just
both.
got rejected. Oh my god.
That's okay, she rejects me too. That's why I put you two together, because you're so most inclined to work alone.
You said a 9-year-old?
I don't remember.
I thought you said the
6.
But you put her alone before I got here.
That's true. Because she's good at math. What I'm gonna have to do here is give you half the information and then you half the information.
I forgot the question. I just need this paper.
Sure.
I'm thinking more of what he had said.
Isn't it funny that it's like at a certain point you're like, it's just easier to do the math, like the formula, instead of like cheats, and that's kind of the ultimate point I'm trying to make. It's like, well, decimal this way, decimal that way. Actually, if I just punch this in a formula, I can just whip it out.
But, okay, no, so it would be divided by one, which is just one. Would be 2.25.
All right. What do you got? 2.25 bananas? Okay.
Oh, milliliters.
Milliliters, right? Okay, so let's kind of back up. I said 6-year-old, right? Tina, how much does average 6-year-old weigh, or what are we assuming?
22.5 kilograms.
Fantastic. What's my dose, Destiny? I almost said Daisy, that's fun. What's my dose, Destiny?
0.01 milligrams.
0.01 milligrams per
Kilogram.
Therefore, Nadia, what's my desired dose? Like, how much am I trying to give in milligrams?
Is it the 0.225 or is the 0.225? Okay.
Sure.
Cause that part I kinda get.
Because you'll move it twice, so we'll move it twice. It'll be easier when I teach you the formula. So 0.225 is essentially the amount I'm looking for. But now the question is how the hell do I get 0.225 out of this thing? And that's where it comes into the situation of
That's right.
you can either move decimals or go through the finality of the formula. Which comes to, Trinity, how much? 2.25 milliliters. Here's what I want you to do.
Okay.
I want you to attach your cardiac epi. I want you to just push out 2.25 milliliters onto the puppy pad. 2.
From the 23.5 kilograms.
Oh, that's where you got it wrong. It's 22.5.
22.5.
Basically, everywhere in between your fingers is plus 2.5. So it's like 10
Yeah.
or 12.5 or 15, which is 17.5, or 20, which is 22.5. Cool. Push it out, nerds.
You said 2.25?
Yeah.
Are you trying to work through
So
the
the
formula?
final answer was 2.25.
Okay.
Milligrams. So that's gonna be 50. Yeah, kind of like in between those two.
I kind of maybe am I right on this?
Beautiful. The drugs.
Yeah.
Thing to do.
So the idea would be is if I'm working the idea would be what do I want to give? I want to give 0.225. 0.225 milligrams divided by what do I have, which is 1 milligram. It's, yep, I have 1 solid and 10 liquid, right? So 0.225 divided by 1 is
Yeah.
this itself, right? So now I do times my quantity for my liquid, which is 2.25.
Get it tattooed on your hand at this point. Just
get one
tattooed on you, just like the backs of all of your fingers, and then you're just like,
However you get, so did you push out
and then eventually you just like
2.5
pull
liters?
somebody off.
Push
while
out
you're trying to, like,
2.25, working on it,
On one of the slides it said like SQ. What is that?
sub Q.
Except you, good skin.
We actually will learn that. I don't think we should be. To push out 2.25, okay? 2.25, very good.
Subcutaneous.
Yeah. What it means essentially, has anybody in here got a TB test?
Yeah.
Oh, wait.
Oh.
That is actually intradermal, I think.
Right.
Oh, yeah, 'cause it's like, is it?
I think so.
So I remember like the skin test, they just kind of like did this and then just like middle bubble.
Yeah, the idea is that you are giving it subcutaneous, essentially, so just under the cutaneous tissue.
And then just like
I
bubbles
think the
up.
TB one might be not sub-Q. I don't
I
remember.
don't know. I just remember that like they
They
made a
look the
bubble
same.
and then just kind of like
They look the same, but essentially
go
the
down
idea
in
is that.
Michigan.
The reason why, I mean, we'll be teaching it, we'll be administering like a little bit of sub-Q saline and stuff, just so we can say that we did it. The government requires that I track that you did it. The truth is what is happening during an anaphylactic shock, right? Let's say. An anaphylactic shock is occurring and we're shunting, right? We're shunting everything from our peripheral. What's up, man?
Yo, it looks so official in here. I'm getting pictures.
Oh yeah.
Alright guys, everybody look natural. Perfect.
Okay.
You hanging out?
We're just all giggling.
I need them to do something.
Oh.
I refuse.
I know.
Ah,
I'm so
okay,
scared in
well,
the
that
air.
means you
I was
can't
like,
be
man,
in
that's
Shit,
the
everywhere.
I need the purple performance.
Wait, I'm like, what?
Class.
Sure.
Do it down.
Hey guys, I'm just gonna bust in real quick and interrupt. So this is a new course for you guys. EMT is closed out, you guys finished it. So with the State Office of EMS, they view this as a new thing. So I have to get new FERPA forms. These are the things that say I'm allowed to share your information with the State Office of EMS, which you can decline to fill out, but it means that
You can't
there's
be
no,
here.
there's no point in being in the program because if I can't share your information with them, then they're not gonna give you a license, so. Anyways, that's what I got for you. Can we take just a moment to get that done? Yeah, is that okay? All right,
I like getting my certifications.
I know you guys got
Thank you.
fluids out, so let's try to keep these dry.
Nice.
There's a couple
Yeah.
people maybe you don't have to give the form to because they're just likely to fill it.
Oh, did I give you one too many? Oh, wow. We're counting my.
You done with this?
Thank you.
Kind of joking.
Right? Get hand heavy tattooed. It gets easier, kids. I'm not saying you'll regret that tattoo, but you might find it's unnecessary.
I am so bad with my, oh, okay,
Yeah,
sure.
just send you